For a long time, certainly in my career, the big killer or the big public health concern has been smoking. But now obesity is right up there and perhaps even overtaking.
Hi, welcome to our latest Goggle Docs podcast. Today, we're going to be talking about the ever emerging and important topic of obesity. Now, this is an area that I think affects so many people around the world, and increasingly so. Talking from my own experience in my clinic, in my practice in London, I'd say over half of the people who have appointments with us are affected by being overweight or having obesity. And it has far reaching effects, really, not only from a physical perspective, but also the image as well that's related to being overweight or having obesity. But then those physical impacts are not only there in the present, but the long term implications as well with the complications. Effects are also there psychologically and socially as well. We're seeing lots of impacts with weight there also. So this is an area that I think not only we're getting a better understanding of, we're having to interact a lot more with our patients with, but we're getting more of an evolution with management as well. And I think that's also a really important area, and how we marry up those two issues of an increasing problem, but also how we get in the management into that arena as well. So, Patrick, as a fellow primary care physician, perhaps you can give us a little bit more of an understanding of how we define obesity and the things that we need to consider when discussing this with patients.
Well, I suppose the definition really comes from the World Health Organization. So they would say that overweight and obesity are defined as abnormal or excessive fat accumulation that may impair health. So, in terms of how we measure it, the typical thing I think we all are using in clinical practice, probably most commonly, is the BMI. A little bit Caucasian centric, this, but they would generally define this as overweight above a BMI of 25 and an obesity above 30. There are lower cutoffs, which for Asians, for example. But even they're a bit controversial and a little bit arbitrary, I would say. That's probably a discussion in its own point, so I won't dwell on that too much. But really, I suppose the focus on this talk is really what the clinical burden is in terms of obesity. Amar, do you want to just lead us through that?
Yeah, I think it's important to perhaps talk a bit about the kind of the epidemiology of obesity from a worldwide perspective, but also more close to home, I'd say, and maybe we'll touch a little bit on the USA as well. But if we look at worldwide, we've seen similarly with type 2 diabetes, the prevalence and incidence is increasing over the years. Similarly with obesity, over the last 50 years or so, there's a tripling in the prevalence of obesity since 1975 or so. And then if we look at things, for example, in 2016, the data was looking at it saying about 650 million people were obese. And if we look at kind of the projections for the next, say, 5 to 7 years, by 2030, we're looking at over 1 billion people with obesity in the world, which again is significant numbers. I think what is quite interesting also is looking at mortality, kind of some of the data from epidemiology and mortality, and saying that people who are overweight or obese and they're dying more with overweight or obesity than with being underweight at this point in time, which drives and highlights how much of an impact this is potentially having and will have in the future as well. And it's not just adults, also children as well. And we know that about 39 million children less than 5 years old or so are dealing with overweight or obesity. This is 2020 data as well. So again, massive impacts across the whole generations effectively, and things that are increasing, constantly increasing over time. But it's not just the world. I've always said actually, we should always look to kind of the USA first, and then see how that impacts the UK. We saw it with type 2 diabetes. We've seen that in obesity as well. If you remember, 15 to 20 years ago, there's about a lot of media coverage about Texas being the largest, not in terms of surface area, more in terms of the obesity prevalence.
They say everything's bigger in Texas, right? That's the tagline, isn't it? Yeah.
So we saw that about 15, 20 years ago, and kind of thought, okay, that's in the USA. It's not going to affect us in the UK. But as we're seeing a lot of things, type 2 diabetes in youth, we talked about that recently. We're seeing that trends from USA and now UK. I think it's nice to go to some of the USA data because, again, that will illuminate a lot about what's happening with our side as well. And really, the data from the US CDC really shows that about 42% of people are dealing with overweight or obesity in the US, really. This was kind of a few years ago data, but still relevant. And then the medical costs associated with obesity in the US, this was 2019 or so, was about $173 billion. And this is before the kind of a lot of the modern data and medications that we have now. So already at that point, it was a significant impact on healthcare costs, and you can imagine how much that would be now and projected in the future, given what I told you about the worldwide prevalence of obesity. But looking at the UK specifically, I think that's what we being UK clinicians, this is where we really focus. And again, it's similar and probably increasingly kind of worrying, I'd say, in a way, because we have to be more aware of the impact it would have. But 26% of adults in England are classified as obese, and about 38% as overweight. So again, significant numbers, almost 50%, not quite, but getting there. And you can see with the projections where it may lead to. A majority of these people are between 45 and 74 years old. So again, a large bulk of our population. And then when looking at ethnic groups, we're talking a bit about this, the cutoffs are different, but really from the data from the NHS, it's essentially a large portion of the black population and Caucasian white as well, are the key components of that, which make up a number of people with obesity. And I think that's quite important from our side when we're looking at, I guess, population planning, disease management, and what we do next. That really helps put into perspective of what we're dealing with in this country.
Yeah, some very stark data there, isn't it? And I suppose what interests me as a clinician is what sort of clinical burden does this then have, particularly not only on people living with being overweight or having obesity, but then also on the health service as well, and what sort of impact that has, because long-term conditions do have a significant impact on the running of our health service, the budgeting as well. And when we look at the figures, we see that over 1 million hospital admissions have obesity as a factor, a contributing factor. That's a lot of hospital admissions when you think about the ongoing costs that come with that. And in terms of directly being attributed to obesity, we have over 10,000 hospital admissions a year. So that, again, huge numbers. What's interesting, though, I think, again, from a primary care perspective, is that we're seeing these significant number of people being affected by this problem, significant number of people being admitted to hospital. But where does the management go? Are we improving? Now, I know we are going to move on to talking about the various different options that we have now. But if we look back at the trend over the last decade or so, we can actually see that there have been fewer prescriptions and items that are being prescribed, particularly in primary care, to deal with weight management. And so that's been the trend. So a little bit of a perfect storm being created there. So rising number of people being affected by obesity, rising number of hospital admissions, but we're not seeing that being mirrored in terms of management. That's changing. But I think what we did have when I started in general practice was Orlistat, and perhaps we'll talk a little bit about Orlistat as well going forwards. But that's an interesting situation where what we've been in the last 10 years, but that's now changing. Before we get to that management side, though, Patrick, cardiovascular disease and its association with obesity, as clinicians, that's what we're really worried about as one of the big hitters in terms of impact. Tell us a little bit more about the correlations there.
Yeah, I mean, the link between cardiovascular disease and obesity and being overweight is not insignificant. I mean, we're talking that's not only the commonest cause of death. In fact, 53%, so the majority just of deaths in people who are living with obesity actually come from cardiovascular disease, both strokes, heart attacks, etc. And and that equates to about 31,000 deaths in the UK per year, or if you like it, each day. That's 85 every day. People are dying with a BMI above 25, and I suppose for a long time, certainly in my career, has been the big killer or the big public health concern has been smoking, but now obesity is right up there, and perhaps even overtaking obesity. So all of that, so all that burden of disease with cardiovascular disease. So I suppose the question, Amar, is in terms of, so we know there's this strong link. Where are we with treatments in terms of trying to reduce that, or just give us a bit more background in terms of that breakdown of cardiovascular disease, a deeper dive, perhaps?
Yeah, I think it's interesting to when you look at obesity, you automatically come to mind. You think, okay, waist circumference or weight. But I guess it's interesting to take a step back and say, well, what's the data looking at that weight, and how much does weight impact on cardiovascular disease? We are talking about cardiovascular disease here specifically. So, what does that weight impact specifically? And the data really comes from a nice trial looking at a cohort kind of population, prospective cohort across Europe, looking to see kind of people who were classified as metabolically healthy. So by that was different. They did not have problems with their blood pressure, with their glycemic burden, lipids, and their waist circumference was in that normal range. So they looked at this group of people who were metabolically healthy and compared them to different sections. So metabolically healthy and normal weight, which was the kind of control, and metabolically healthy and overweight, and metabolically healthy and obese. And then also metabolically unhealthy, so they had one of those risk factors that I mentioned, and then normal weight, overweight, and obese. And what they found was that the trend, even if you were metabolically healthy but were overweight or obese, your cardiovascular risk increased. And if you were metabolically unhealthy and had normal weight, risk further increased, and then overweight, obese. There's a constant increase in that risk of cardiovascular disease, highlighting that it is as much about weight as it is about the risk factors as well. And I think that was quite a nice study to look at to kind of really put that into kind of perspective, really. And it's really not just about the cardiovascular disease, also the mortality side. So what we see is a U-shaped curve. So in people with low BMIs, there's a high risk of mortality, and that's partly because of frailty and underweight and malnutrition, that side of things. But also, as the BMI increases, you're getting increased risk of mortality as well, highlighting again further, not just the morbidity, but the mortality side of things, and why it's so important really to manage our patients from the weight perspective, both sides, but certainly in the overweight side as well, because of that impact on the person and the healthcare system as a result. What we're going to ask me next is, why does this happen? And kind of not quite pathophysiology, but there's a lot of understanding of what puts someone into that risk, someone who's obese or goes into obesity and then into those risk factors. And it's kind of like a progressive stage of things. So you have someone's genetic makeup, their predisposition, their genetic predisposition, that starts even before they're born formally, once they're in the womb, and then progresses well from the genetics as well. So you've got that. You've got the environment as well, the obesogenic environment that we live in nowadays, and all the impact that does have, as well as caloric intake, energy expenditure as well, being healthy, so to speak, if that makes sense. And that starts the process of increasing the weight, increase the fat depositions in all the organs and all the sides of things. And that leads to kind of depositions in organs, the effect on the endocrine systems, the immune systems, the organ systems, and that will cause the disease processes. So things like type 2 diabetes, dyslipidemia, hypertension, those kind of conditions, which then further impact the cardiovascular risk and then result in disease states and cardiovascular disease, mortality, morbidity. And you've got that stepwise progression. So you can intervene either once they've developed it, once they're at that cardiovascular disease, once they've got it, once at the risk factors, hit the risk factors, type 2 diabetes, hypertension, dyslipidemia, or you hit the environment, hit the kind of the energy expenditure earlier on. So you can hit any one of the stages. Ideally, the earlier you go, the better. But it just shows kind of it's a progressive kind of stepwise kind of progression of the disease processes.
Okay, so we've painted quite a detailed picture of the challenge that we face with obesity, the journey that then progresses, and the risks and the complications. So let's consider the management now, because as I've alluded to earlier, in the last decade, perhaps the options that were available were relatively limited compared to where we are today in 2023. But I'd like to start by looking at the management from a biopsychosocial aspect, and in particular, focusing on the psychological aspect first. Making changes to lifestyle, the psychology behind that is something that us as clinicians really need to appreciate and share that conversation with a person living with obesity. But then the psychological impact that we can't ignore, the other mental health conditions that can also occur in line with obesity, anxiety, depression, etc., and how we ensure that the management of that is integrated. Going on to the social aspect, which I think is really critical in obesity, is the access to interventions and management, the accessibility to that, the affordability in different health systems and different societies. And I think that can be a real divider, as is the case with many long-term conditions. And people perhaps who need it need intervention and support the most, often not being able to access that. And then stepping a bit further back from that social kind of challenge, where does government and public health organizations come into the picture? Because again, with obesity and weight, the driving factors often are things such as access to healthy foods, access to activity centers and things like that. So there's a real social element to it as well. If we look at South America, they perhaps lead the way with some of their health policies in terms of taxes on processed foods. We saw that in Colombia, actually, haven't we? And then earlier on in Mexico, the sugar tax. So these are ways in which perhaps government is helping to address some of those social inequities and ensuring that there is perhaps more access to healthier choices for an individual. We don't perhaps know what the long-term benefits of those interventions are just yet, but I think it just paints a picture of how complex the management of obesity really is, even before we get to start talking about medicines. And so those lifestyle measures straight up, how we go about ensuring that we're optimizing that, it's quite a complex situation, isn't it? Do you want to speak to that, Amma?
It's just to say, when you mention that, it's highlighting costs involved of that as well to the individual. Yes, the cost of the government, but the individual as well. We say healthy living, healthy eating. Gym memberships come at a price. So does healthy food, and you could put taxes on the food and unhealthy food, but equally, you need to make healthy food readily available as well.
Exactly.
So it's both sides. So it's really, and this is why we need government support and government policies to do that. Because as if you remember what I talked about, the progression is that obesogenic environment.
Yeah.
We're living in that. We've seen that. We've seen that in our country and beyond, and trying to address that. So steps are being taken some places. A lot of people want to see what that shows and what effect that has. There's some data on the sugar tax in Mexico, but I think we kind of have to kind of work towards that from a government, but also grassroots upwards as well, to try and support and try and drive that change.
So I think it's really important to have that perspective, but I know we're also really keen to talk about the scientific advances as well in terms of therapeutic options that are available. And Patrick, I know that's an area of particular interest of yours. Give us a bit of a flavor of what we have available.
Yeah, I mean, obviously, the basis of all weight loss, really, or sustaining weight loss, is going to be on that physical activity and what people are eating and doing. But sustaining that behavioral change is a real challenge. We can see that as good evidence in the direct study, which is a weight loss intervention to put type 2 diabetes into remission, with the vast majority of people over a 5-year period of time saw weight regain. And it tend to be life events. We can't necessarily inoculate people against life events. So I think other interventions, such as surgery and maybe medicines, that we could, can help where that behavioral intervention is difficult to sustain, because these potentially have a longer sustainable effect. And so if we're looking at bariatric surgery, there are 3 main bariatric surgical methods which are used. So that would be laparoscopic, adjustable laparoscopic banding. More commonly, I suppose, these days we see the gastric sleeve and laparoscopic bypass, gastric bypass. So, and I think, so that's just very briefly the surgical interventions. But when we're talking here about cardiovascular disease, Amar, and so what's the evidence behind these interventions and actually reducing that leading cause of death in obesity?
It's interesting, isn't it? We've had bariatric surgery for some time, and we know it's fairly effective in that weight reduction. We always compare a lot of medications to saying they're equivalent to bariatric surgery or so. So we accept that it's a very good treatment for weight loss, balancing the side effects and what it involves as well. But and long-term cost effectiveness has been looked at, certainly in the setting of type 2 diabetes. In terms of cardiovascular disease, we perhaps don't have that strength of evidence because, again, it's long-term follow-up and management and reviews, and we don't have those prospective kind of randomized controlled trials to really look at that cardiovascular impact and accounting for the variables. So it is a bit tricky to say. What we do have is kind of retrospective looking data. That's people who've had bariatric surgery, following them up to see kind of what happens in their cardiovascular risk and mortality. And essentially, there's a nice study looking at last two you mentioned, gastrectomy, sleeve gastrectomy, and room-wide gastric bypass, and looking at cardiovascular risk and mortality, and essentially showed that people who had those operations were less likely to die from major adverse cardiovascular events, heart attacks, strokes as well. So it was the data's there, and heart failure as well. It perhaps didn't show clear in terms of AF and atrial fibrillation, but apart from that, generally those main cardiovascular diseases, it did show benefit. It wasn't an RCT, it wasn't fully prospective, so we can argue that point. But it does provide some evidence saying, yeah, bariatric surgery does tend to suggest improvements in those parameters, and should not be ignored when we're talking about when we're getting, caught in the maelstrom of medications and treatments. That bariatric surgery is still there and still will be there, so still should be considered.
Yeah, absolutely. And I think some of the results from bariatric surgery are quite impressive and significant, aren't they? But it is surgery nonetheless. And I think that is quite a major hurdle to cross for many people and for clinicians to consider for their patients as well. So I go back to medical therapies. I go back to when I first started in primary care and what options were available to us then. And it was essentially Orlistat, which I perhaps and my patients have a love-hate relationship with, because the offer there was an oral therapy to aid weight loss. And I think herein lies one of the challenges. And I think we were talking earlier on about this, Patrick, off air, which was about what does success look like to a patient in terms of weight loss therapy compared to what success looks like to us as clinicians who may have a more, well, hopefully more of a 360-degree view of the condition. So perhaps for a patient, the first thing they notice is, am I actually physically and looking in the mirror, image-wise, losing weight? And I think that was perhaps one of the disappointing things with Orlistat, the feedback that I got from my patients, at least. The other challenge was the adverse event and people having to rush to the toilet, so the gastrointestinal side effects of Orlistat. So I generally found in my practice, people were not, remaining on the therapy for long enough, perhaps to see sustained results. But interestingly enough, as well, we have population level data, cohort study data that shows for those people who did remain on Orlistat, there is evidence of reduction of cardiovascular events. I think there's a particular cohort study that showed somewhere in the region of 25% reduction. So again, it's that conversation that we have with our patients. Are we both on the same page in terms of what success looks like? What are we trying to achieve through therapeutic options? Is it the image? Is it the weight loss? Or is it actually those reduction of long-term complications? And I think in Orlistat, that's a nice example of where that becomes a bit of a challenge. But we've moved on from there, haven't we, Patrick, in terms of where we are?
Yeah, we do. And I'm going to just talk a little bit maybe about GLP-1 receptor agonists, but just going back to what you said about experience in primary care with Orlistat. And I think it is, I think that's because often the people we're prescribing Orlistat, we're not actually doing it for cardiovascular protection or prevention, rather. We're doing it really, as you say, for people who are coming and say, I want to lose some weight. So they're often looking at much shorter term timelines. And also, after a period of time, these drugs stop working, and then in a sense, the motivation can wane. So GLP-1s, we're going to be, being used for a long time in type 2 diabetes, where quite clearly, as well as weight loss, we're looking at glucose reduction, but we're also looking at that cardiovascular protection. And we've known for some time that these drugs are really useful, certainly at least in high-risk patients with type 2 diabetes. And there was a really decent meta-analysis which showed really that there was not only the GLP-1 receptor agonists lose weight, but you get this reduction in major adverse cardiovascular events, cardiovascular death, MI, stroke. So, with clear benefits. Of course, there's always harms with treatments like this. There are adverse GI side effects. You mentioned Orlistat. There's different GI side effects, but they certainly are, particularly when you start and titrate up. But there's also, increasing concerns, for example, on gastroparesis in anesthesia, as people are often getting these treatments outside of perhaps routine NHS medical care if we're in the UK setting. So I think in type 2 diabetes, yeah, they work, but we're dealing with a high-risk cohort where we're often talking about cardiovascular benefits. But I suppose if we just go into that obese setting without type 2 diabetes, what's the data when we're looking at GLP-1 or agonists, for example? Tell us a bit more about those.
Yeah, so it's almost inevitable that people would look at incretins in the setting of obesity and overweight because they work. That was one of the main reasons why they were using type 2 diabetes, that added benefit really with them. So to see them in a pure weight management kind of category, it was coming. And we saw it earlier on with the first molecules. liraglutide, and this was liraglutide 3 milligrams, so not the 1.2, 1.8 we use in type 2 diabetes, but the 3 milligram higher dose, Saxenda, you might know it as. And this was really used in the scale studies, so looking at the weight management. Now, there wasn't a cardiovascular outcome trial. That wasn't considered at that point, but they can look at cardiovascular risk reduction based on risk factor management. And they did that based on kind of post-hoc analyses of the scale trials and said, well, actually, yes, liraglutide seems to reduce the risk of these composite outcomes, 3-point MACE, MI, and cardiovascular mortality based on that. So a retrospective review of the data. And that was the best we had at that point, saying, yeah, it hits those kind of cardiovascular risks, so therefore it must reduce, it projected to reduce those outcomes. And then similarly with semaglutide, so the next molecule in that class, this is the 2.4 milligrams of semaglutide, not the 1 milligram and 0.5 that we use in type 2. So this is the highest strength obesity dosing. And again, they looked at data from the STEP trials. And they looked at, again, the cardiovascular risk reduction, the risk factor reductions, and therefore implied that actually it will have impact on cardiovascular health as a result. So up on this point, you see what we're getting at. We're looking at risk factor management and as a proxy for actual, prospective cardiovascular risk trials and outcome trials. But that changed really recently, about a month or two ago. In the American Heart Association, they announced the results of SELECT, which was semaglutide in those with overweight or obesity, but without diabetes. And this was actually a first cardiovascular outcome trial with incretin in that setting as well. And that actually showed a risk reduction of 20% if you're on semaglutide versus not being on semaglutide in terms of the 3-point MACE, essentially, showing that actually obesity is, as I said, a modifiable risk factor for cardiovascular disease. And it's quite, it's the first in of such trials. And it, kind of moves forward from where we were before. We're looking at not just weight lowering, but actually the long-term benefits and specifically cardiovascular disease. And which is why when you mentioned earlier, Amrit, about prescriptions going down over the years, that was partly because we didn't really have anything in terms of these medications. We had all the stats you mentioned, and in the UK, not really much else. In the US, we may have some other options. In the UK, not much. And now, hopefully, we're excited to see that that trend's going to be slightly going upwards and moving further upwards over time, because it's not just semaglutide and liraglutide for weight management. We now have another class of molecules, the GLP-GIP, tirzepatide, which we're hearing a lot about these days as well. And they haven't got the data yet for a cardiovascular outcome trial, but they have looked again, as you can see the trend here with the other molecules, looking at cardiovascular risk factor reduction to see if that impacts on cardiovascular disease. And they looked at that with the SURMOUNT trial, SURMOUNT-1, which again is an obesity trial for tirzepatide, and looked to see kind of does the projection for the risk factor reductions translate to atherosclerotic cardiovascular disease reduction, and the data showed yes, it did. Again, in the absence of a cardiovascular outcome trial, that's what you have to do to kind of show that maybe this, food for thought. But they do have a cardiovascular outcome trial coming at some point later in the 2020.
Yeah, 2027, I think.
2027, yep. And that's the SURMOUNT MMO, which is looking at cardiovascular outcomes in those with obesity with tirzepatide. And that'll be something interesting as well. That'll further drive forward the discussions that we're having, and then add further kind of, no pun intended, also further weight to the discussion about cardiovascular disease. But I think that's still some time. I think that shouldn't stop us from doing things now and really impacting that weight. I'm sure you'll agree.
Yeah, no, absolutely. Guys, I think we've covered so much over this podcast. I think there are a few things that really stood out for me. And I think I'll just highlight those now at the end here. So one thing that you mentioned, Ahmed, that really stood out was looking at America and the trends that occurred there and following that and tracking that across to Europe and then over to Asia. I think that's a really interesting point that you made there. We saw that with the type 2 diabetes rates that were kind of increasing quite rapidly and how that progressed across the world. Similar sorts of things we're now seeing with obesity. So that really struck a note with me. But also the cardiovascular associations, Patrick, that you highlighted as well. And the burden that then creates not only on the individual, but as a clinician and our health systems as well was quite notable. Another area is, I suppose, it talks to this art of medicine where we as clinicians have that responsibility of ensuring that we're bridging the gap between the person with the condition and their objectives in managing obesity which may potentially be more image and weight focused compared to our objectives, which might also include the long-term complications and addressing those. And how we marry that up, I think, is really important. And you made a really nice point there, Patrick, about the person who comes to the clinic asking for help regarding weight doesn't necessarily have in their mind reducing their cardiovascular risk, because that may not have been part of the conversation. I think that's a really important part for us as clinicians, but also potentially as governments and society to be having more of a focus on as well, that the effects of weight and being overweight have very far-reaching kind of consequences. And how that all fits in with medicines, with GPs, secondary care, and with government and public health, and talking about costs of and access to healthy foods and places to exercise. I think it is quite a complex area, but I think the appreciation is the starting point for all key stakeholders involved. I don't know what your thoughts are, but I think this was a really interesting kind of discussion, and it's highlighted some really key areas for me.
I suppose from my perspective, I think it's, as you say, there's a lot to do. There's a lot that every aspect of society can be involved in. I suppose, we're all docs here, so we need to focus perhaps on the medical aspect, but that's not to say there aren't really important societal, political, policy decisions. In fact, I think they're arguably more important, but they're also more challenging. And you know what? It's challenging enough just to try to manage the medical aspects of this, never mind looking beyond. So I try to focus on the things for my own mental health that are in my control.
I think whatever you look at, the key thing to mention is this will be costly. From a policy government perspective, from an industry perspective, and from healthcare perspective, it all will be. But so will the consequences of what we do as well. And it's just finding that right balance, and not shirking the responsibility that we all have. And I include everyone, that whole cross-party working, as Patrick mentioned. It's not just the government, it's not just clinicians, it's not just the patients, it's not just the groups, it's also industry, it's also food industry, it's the pharmaceutical industry, everything. If you truly believe in that, then that's really kind of what we should be doing, and it remains to be seen.
Brilliant. I think we'll end our podcast there. Amma, thank you so much for your insights. I know this is an area where you've taken more of a deep dive recently, with your background in diabetes, obviously as a diabetologist, obviously a very important area. So thank you for your insights today. Patrick, as a fellow primary care clinician, I think it was really great hearing your insights and how relatable this is on a day-to-day basis for us in primary care. I hope everyone has enjoyed this podcast. As you can probably tell, there's a lot more to discuss in this area, and I'm sure we'll be following up with more content. Do keep following us across our various social platforms. We're on X as well as on YouTube. Feel free to engage with us there, and we look forward to seeing you again soon. Take care.